let's start with, can you see the slide?
Yes, sir.
Okay. So let's define shock. All right. So there are so many components in shock. Shock is defined as there is an acute hemodynamic disturbance which causes a reduction in the capillary blood flow with decreased tissue perfusion and anoxia. So four components are there, right? Firstly, there is a disturbance in the circulatory system. Once there is a disturbance, then definitely there is reduction in the capillary blood flow. So once it is a known fact that whenever the supply is low, the perfusion is definitely decreased. And anoxia. Anoxia is a term not very commonly used. It's really hypoxia. Anoxia is total absence of oxygen. So hypoxia, I think, would be a better term here. But however, the authentic books describe this as a definition. So it's a acute hemodynamic disturbance causing reduction in the capillary blood flow with decreased tissue perfusion and anoxia. So there are some changes that happens in shock. So the shock is basically manifested by changes in blood pressure and pulse rate, which is indicative of cardiac output. Can you see the slide?
Yes, sir.
Yes, sir.
Okay. So there are changes in the blood pressure and pulse rate that is indicative of cardiac output. You know, cardiac output is the amount of blood that the heart is pumping every minute. The other thing is the skin temperature and color, right? So that is indicative of peripheral resistance. So in shock, what happens? The peripheries do not get enough supply. So one of the main components during treatment in shock is you do not give anything intramuscular because there is less perfusion. All right. So whenever you're treating shock patients, the golden rule is just it will always be to give the patient intravenous medication. Intramuscular medication has no role in shock cases because the perfusion is low. All right. And the other thing is state of venous filling and color of the nail beds. So this will tell you the indication of the circulation. So how much blood? This is indicative of blood flow. And urinary output. This is indicative of tissue perfusion. Usually what happens in shock is the patient has oliguria. Oliguria is defined as urine output less than 400 ml in 24 hours. So one of the best parameters of saying this hydration status of the patient is to measure the urinary output. If the patient has urinary output less than 100 ml per 24 hours, the patient is oliguric. That means the patient is severely dehydrated. There is not enough fluid in the body. And thus there is a problem with the circulation. Okay. So the normal urine output in 24 hours is like 1 liter to 2.5 liters, depending on the amount of fluid intake. So if somebody is having less than 400 ml urine output in 24 hours, that is an alarming sign for you to say that maybe the patient is having some form of circulatory failure or the patient may be in a state of severe dehydration. Okay, so hypovolemic shock, we'll be talking mostly about hypovolemic shock today because the topic is hypovolemic shock. Basically, hypovolemic shock occurs because of massive loss of blood. The blood loss can be either through many causes. I'll come to that. So it is also known as cold shock. One of the reasons patients develop hypovolemic is shock is the loss of blood or fluid from the body at a very rapid pace. That is why if you see surgeons operating in the operation theater, when there is bleeding, the surgeon panics because he knows that if the patient loses blood too fast, he may not be able to save the patient. For example, if somebody has, say, if somebody loses 1 liter of blood in 10 days, the patient may have a normal behavior. There might not be any changes in his body. But if the patient loses 1 liter blood in less than 5 minutes, he may not live, he may not survive. So you see, it's more of a time. What should I say? It's more, blood loss is more dependent on time. So if you lose blood too fast, then definitely you have hypovolemic shock. So what are the signs and symptoms of hypovolemic shock? So if you look at the patient, if you measure the blood pressure, the patient is hypertension, there's low BP. Okay, there is rapid thready pulse. The pulse is very feeble. There is so little volume. All right, so it's very thready. And then cold. Patient is really cold because of circulation failure. Pale. All right, patient is very pale. If you look at the patient's face, the patient, it looks like the patient does not have any blood in the body, so it looks pale. Clammy skin. Clammy skin. The skin is very clammy, little kind of moist. And if the patient is still conscious, the patient will complain of intense thirst. All right. And then there is rapid respiration, tachypnea. All right. And restlessness. The patient is really restless. And reduced central venous pressure. So if you have put a central venous pressure in the internal jugular vein, the normal central venous pressure is 7 to 10 centimeter of water. So if the central venous paper is raised, that means there is a lot of fluid in the body. If it is reduced, that means there is a reduction of fluid in the body. So there is less fluid in the body. So one of the parameters or one of the ways to find out how much fluid a patient needs is to put in a central venous catheter. So if you measure the central venous pressure, you know exactly how much fluid the patient needs or how much fluid the patient is having. Can you follow me?
Yes, sir.
Yes, sir.
Okay. So what are the causes of fluid loss in hypovolemic shock? Well, I was telling you blood, right? Externally, when there is an external injury like road traffic accident, somebody sustained massive injuries and you can see visible blood coming out of the human body, hemorrhage. Okay. So, and then gastrointestinal bleeding, right? Externally, we have categorized this as gastrointestinal bleeding. So if somebody is bleeding from any, in gastrointestinal bleeding, either you have hematemesis, which means vomiting of blood, intestinal tract, the patient is bleeding and it has come out as a, in the form of black tarry stools. So one of the important things for you as a clinician is if the patient has frank bleeding from the rectum, which is known as hematochezia, and the altered blood is known as malinia. So if the patient has melena, you should always think that it is bleeding from the upper gastrointestinal tract, somewhere in the stomach or small intestine. But when there is lesion in the large intestine or the colon, then you have fresh bleeding. On top of that, the other causes of perrectal bleeding are you could have growths, or the most common cause definitely is piles, all right, hemorrhoids, and they are situated in the rectum. So that is, if the patient is losing a lot of blood externally, you can have hypovolemic shock. Internally, yes, the patient can have internal hemorrhage, or this is also known as concealed hemorrhage. All right, you cannot see any blood coming out from the body, but it has collected in the human body in the third spaces like fractures. immediately to save the life of the patient. The other is plasma. All right, plasma loss is usually in burns. Burns is a very major problem because it really dehydrates all the tissue of the human body. There's a lot of plasma that is destroyed. Now, if you look at the total amount of plasma in the human blood is something like 3.5 liters, and plasma contains all the important elements. So in burns, one of the major damages is to the plasma. So a lot of damage is done. The other cause of plasma loss is inflammation. All right. So if you have any inflammation, either it's minor or major inflammation, you have the exudate. In fact, in pancreatitis, the inflammation is so much, as I just mentioned earlier, you can lose up to 6 liters of fluid into the peritoneum. Are you following me? Are you following me?
Yes, sir.
Yes, sir.
Okay. Now, the causes of fluid loss in hypovolemic shock still continues. The extracellular fluid loss. All right. So we talked about the blood, we talked about the plasma. Now the extracellular fluid. How is it lost? So there is sometimes deviation of normal exchange mechanism at the transcellular level. All right. So this mechanism is at par, and then you have gastrointestinal losses. All right. Vomiting. All right. Massive vomiting. Fistula formation. Fistula is an abnormal communication between two viscera. All right. So renal losses in diabetes insipidus, you have a lot of renal losses. So a lot of fluid loss can lead to hypovolemic shock. The other cause is increased extracellular loss along normal pathway. This is very interesting, as in excessive sweating. So, right. So most of the athletes, when they go for professional games like football or cricket or even, you know, boxing, any game, any professional game which requires a lot of physical activity, the athlete can lose a lot of fluid in the form of sweating. It is said that any professional sports, in any professional sports, an athlete can lose up to 6 liters of fluid in 1 hour. 6 liters. That's very, very high because the human body has a total of 42 liters of fluid. And if you lose 6 liters in 1 hour due to any vigorous sports, then that could be one of the causes of hypovolemic shock. All right. So that is why you see when you're watching a professional football game, you see that the athlete is pouring a lot of water over the head. All right. So he's losing a lot of fluid, he or she. All right. So one of the causes of fluid loss is during excessive sweat. And then the third space phenomenon, there is in any form of inflammation, there is increased capillary permeability. So that increase in capillary permeability allows free exchange of fluid. So that will lead to excessive fluid loss. And the loss of the biochemical integrity of potassium pump, which results in the abnormal exchange of sodium and potassium, leading to loss of massive fluid volume and then eventually leading to hypovolemic shock. Now, this is, can you see this slide? This is a very important slide. Can you see the slide?
Yes,
Yes,
sir.
sir.
So this is the pathophysiology of shock. I have really simplified it at your level, but this is exactly what happens. So you see in hypovolemia, when there is decreased blood volume, that will lead to decreased venous return, and that will lead to decreased cardiac output. So whenever there is less blood coming into the heart, then obviously the heart is pumping less blood, so decreased cardiac output. That will lead to decreased renal blood flow. Okay. And then regional, when there is reduction in regional blood flow, definitely there is local tissue hypoxia. The cells are not, the tissue is not getting enough oxygen. so particularly the splanchnic circulation, and that will lead to lactic acidosis, and that will lead to cellular swelling. So once the cells have swollen up, there are systems of plasmolysis as osmosis, and there is organ dysfunction. Now the whole organ is not functioning. So when one organ starts to dysfunction, there is multi-system organ failure. So once there is multi-system organ failure, let's say if 3 viscera in the human body fail, the chance of death is, or mortality is 75%. Eventually, multi-organ system failure will lead to death. So that is a vertical line that you can see. Now, lactic acidosis will cause bacterial transmigration. Bacterial transmigration means the bacteria have a normal flora in the human viscera. So once there is a lot of pressure, but because of antibiotics or because of other things, the bacteria will not stay there. They will migrate into another viscera. That is known as bacterial transmigration. So during transmigration, since the bacteria are not living in their own home and moving away from normal, they release a lot of endotoxins. They are scared. They are terrified. So they will release endotoxins. And it is the bacterial endotoxins that is dangerous. Even the coronavirus today, all right? Probably they are releasing a lot of endo and exotoxins that is harmful. It's not the bacteria that is harmful. Remember that. It is the release of their endotoxins, all right? So once they release the endotoxins, there is release of mediators, and these release of mediators have 2 components. One is they will cause myocardial depression directly, which will again lead to decreased venous blood flow. The other is, as I was telling you, as in inflammation, there is increased capillary leak. So once there is increased capillary leak, that will again lead to hypovolemia. Now, let's look at the right side. The hypovolemia will cause they will stimulate the carotid bodies. Via the carotid bodies, catecholamines are released, and the catecholamines will cause peripheral vasoconstriction, leading to decreased regional blood flow. Okay. Now coming down to the cellular swelling, this will cause microcirculatory blockage, and this will again cause decreased regional blood flow. So this is a simple flow chart showing the pathophysiology of shock, revealing many vicious circles. All right, there are more, but I have just simplified it. I think if you can remember this chart, you can understand a lot of pathophysiology about shock. Can you see it? Are you following me?
Yes, sir.
Okay. So now let us go to, all right, let us go to this class of hemorrhage. Somebody has made a class of hemorrhage. They have classified hemorrhage depending on the amount of blood loss, depending on the physiological changes and the clinical manifestations. So they've classified hemorrhage into 4 different classes. All right. They have classified hemorrhage as class 1, class 2, class 3, and class 4. Now, if you can see, class 1 is simple blood donor. So, and then the class 2 is uncomplicated shock. Class 3 is complicated shock. And class 4 is pre-terminal shock. Now, if you look at the blood volume lost, in class 1 donor, there is up to 15% blood volume loss. All right. When you talk about class 2 uncomplicated shock, there is 15 to 30% blood loss. And then class 3, you can see the complicated shock where there is blood loss between 30 to 40%. And then the pre-terminal shock, class 4, you have more than 40% blood volume loss. Now, if you look at the amount, in class 1, it's up to 750 ml. So this is like a simple blood donor where the donor is donating something like 300 to 400 ml, maybe up to 700 ml of blood. All right. And you look at class 2, 750 to 300 ml blood loss. And class 3, you have 1500 to 2000 ml. And in class 4, you have more than 2 liters or 2000 ml. Now, surprisingly, if you look at the clinical features, the heart rate is below 100 per minute in class 1, which is absolutely normal. In class 2, it is more than 100 per minute. Slightly, there is tachycardia, but you're not worried. In class 3, it's more than 120 minute. You begin to worry a little bit because the heart rate is going more than 120 per minute. And in class 4, you're very, very worried because the heart rate is now more than 140 per minute. That is pretty high for an adult. Now, if you're talking about the fetus, that would probably be the fetal heart rate, or that is the heart rate in a newborn. But in an adult, a heart rate of 140 per minute is very, very alarming. Okay, looking at the respiratory rate in class 1, you have absolutely normal. 20 to 30 per minute in uncomplicated shock, or class 2, you begin to worry a little bit because now the patient is slightly tachypneic, right? The patient is slightly fighting for breath. And then in class 3, complicated shock, it's 30 to 40 per minute. It's really, really tachypneic. The patient is really under a lot of respiratory stress. And then in class 4, the pre-terminal shock, it's always above 35 per minute, which is, as I was telling you, it's very, very alarming. Now, if you look at the urine output, which is a very good parameter to see the hydration status of the patient, well, in class 1 is more than 35 ml per hour. That is pretty normal. So you're not worried much. So basically the best way for you to calculate the urine output is, in the adults, it is 1 ml per minute. So 0.5 to 1 ml per minute. Okay, if it goes below 0.5 ml per minute, then you have to worry and think that maybe the patient is not having enough urine output, or maybe the patient is in a form of some form of dehydration. Now, if you look at class 2, it's 20 to 30 ml per hour. It's going down. And then in the third class, where there is complicated shock, it's only 5 to 15 ml per hour. Now, unfortunately, if you look at pre-terminal shock, there is absolutely no urine output. This is known as, so 0 ml per hour is known as anuria. Now, don't be confused between anuria and retention of urine. Anuria means there is no formation of urine. Retention means there is formation of urine, but because of the blockage of some of the genitourinary tract, the urine is not being able to come out. So that is that is something that you should keep in mind. So 0 ml per hour, absolutely anuria. So this is very, very bad. Okay. So one of the things that you should keep in mind is, when the patient loses more than 50% of the blood volume, it will result in total unconsciousness. There's loss of pulse and blood pressure, and you may not be able to save the patient despite vigorous treatment and therapy. So this is actually a very important class of hemorrhage that is frequently asked in written as well as vivas. They always ask you to, sometimes question comes, define shock and classify hemorrhage. What are the types of hemorrhage are in? So please note that this is an important table that you are looking at, right? So how do we manage hypovolemic shock, all right? So assessment and resuscitation. So any patient who is brought to the emergency department, or who is brought to the surgical OPD with a tremendous amount of blood loss, you have to assess and resuscitate the patient at the same time. It is done simultaneously. So as you were beginners, you learned about ABCD, and as a medical professional, you'll also learn about ABCDE. So this is depend on advanced trauma life support, airway. So the first thing you do is you examine the airway, and you make sure that the airway is patent, all right? So if anything is stuck inside the oral cavity, you have to remove it. So one of the very amazing things about I know, I'm sure you've watched Anaconda, the movie Anaconda. There is a scene where this guy does a beautiful tracheostomy. So if anything is stuck in the airway or the pharynx or the larynx, oropharynx, the best option is to do a tracheostomy. So airway, you have to make sure that the airway is clean. So this is A, B, C, D, E. But when you're doing things, this is happening in seconds. Simultaneously, you're looking at everything. You first check the airway and then the breathing. You make sure that the patient is breathing. So one of the causes of apnea or one of the causes of patient's respiratory failure is when the patient becomes unconscious, the tongue falls backwards and it blocks the epiglottis, resulting in respiratory failure. So you have to make sure that the breathing is there. So you put in an airway tube or a Guidel tube, and you give a patient at least 6 to 10 liters of oxygen, all right, through the tube or whatever. So you have breathing has two components. One is you are giving oxygen at a very high flow rate, and the other is you making sure that you can you put in an airway tube to make things potent because you don't want the tongue to fall back and block the epiglottis and cause respiratory failure. All right. Circulation. All right. Circulation is now you have to make sure that if the patient is bleeding from any place, you have to stop that bleeding through pressure or bandage or whatever. And then the other thing is you have to put two IV cannulas. All right. So you open two IV cannulas and you give the patient a lot of fluid. Crystalloids or colloids, it does not matter at this time. This is life saving. Whatever fluid is available, you give at a very high flow rate because you know that the patient has lost a lot of blood and patient has lost a lot of fluid. So you want to replace that loss. So crystalloids are things that are say less than 30,000 in molecular weight. Colloids are something more than 30,000 weight. But at this crucial minute, it is not a debate against crystalloids and colloids. It's a debate. There should be no debate. You just have to give the patient a lot of fluid. And immediately when you put in an IV cannula, you send the blood for grouping and cross matching and get the blood ready and send for other investigations as well. Because when you're going to put in a cannula, you have to draw blood and send for all the basic investigations. Well, disability is something that you have to, you not only see the ventral aspect of the patient, the front side, but you have to check the back side for any loss. All right. So, and then you have to see for any disability. Is the patient disabled? Is there any paralysis? Is there any paralysis? All right. Is the patient moving his arms and legs? All right. Is there any physiologically functional deficiency? All right. So you got to see for that disability. And exposure is you have to see if the patient has any other injuries on the backside. So you have to check the eyes, the nose, the ears, the mouth, the private parts, the rectum, anal canal, everything. So that is exposure. All right. And these patients are always managed in a high dependency unit or ICU unit with constant monitoring. All right. Because these are the patients you don't want to send them home because they will present as a simple patient, but inside the body there may be many physiological changes or biochemical changes that is happening so fast that you cannot afford to send them home. So if you suspect that this is a patient of hypovolemic shock or somebody who is losing a lot of blood or losing a lot of fluid or losing a lot of things to other physiological problems, you have to at least keep the patient for observation for at least 24 hours to make sure that this patient will not develop complications. And this is always done through constant monitoring in ICU and SDU. You might have to put in a lot of, you have to put in a Foley's catheter to make sure that the urine output is there. You may have to give the patient nutrition in the form of, glucose or other, you may even have to give the patients immunoglobulins or human albumin if the patient has a very low protein. So this is how we basically manage a patient with hypovolemic shock. Now, I don't know. The topic is hypovolemic shock. I'm not focusing on other other, let's say, the other types of shock. It was basically hypovolemic shock. So thank you. That's about hypovolemic shock. And remember that you get a lot of written questions on classify shock, define hypovolemic shock, management of hypovolemic shock, right? And then I also told you that they also frequently ask about here this classes of shock. So thank you for being very patient with me. So do you have any questions? Do you have any questions?
Ishim sir.
So,
Yes.
Sir, crystalloids and colloidsले कसरी टिस्यु पर्फ्युजनमा हेल्प गर्छ?
त्यो त अब मलाई एक्ज्याक्टली थाहा भएन, तर यु हेभ क्रिस्टलोइड्सहरू चाहिँ मोलिकुलर वेट 30,000 मात्रै भएकोले चाँडै पर्फ्युज हुन्छ होइन. it is basically a race against time. The crystalloids go into the circulation faster. So whatever you give, you have to give intravenous directly into the circulation. So that is why you should not give anything intramuscular. It has to be in the circulation. Crystalloids दियो भने चाहिँ चाँडै हुन्छ. Colloids दियो भने चाहिँ it does take time. So once you replace the fluid, circulatory failure बाट चाहिँ बचाउँछ पेशेन्टलाई. So the patient will have, and in fact you also give a lot of steroids sometimes, so that is life saving. But whatever you are giving, you have to give intravenous.
Okay sir.
On crystalloids and colloids.
And sir, अनि त्यो बुकमा लेखेको कि they do not have oxygen carrying capacity भनेर. त्यही मैले बुझेन.
त्यो अक्सिजन फ्री रेडिकल नभए पनि त्यो डाइरेक्टली सर्कुलेसनमा दिने हुनाले पर्फ्युजन अक्सिजन त यताबाट दिइरहेको हुन्छ नि त फेरि. इट्स नट द्याट यु ओन्ली गिभ फ्लुइड्स होइन, यताबाट तिमीले 6 to 10 liters अक्सिजन दिइरहेको हुन्छ नि त फेरि. Simultaneously you're giving a lot of treatment all at once. के बुझेनौ?
थ्यांक यू सर. बुझे सर, बुझे.
ओके. अब 6 देखि
thank you,
10 लिटर अक्सिजन चाहिँ तिम्रो माथिबाट दिइरहेको हुन्छ लङ्समा हैन. रेस्पिरेटरी फेलियर होला भनेर तलबाट चाहिँ तिम्रो फ्लुइड दिएको हुनाले चाहिँ बिस्तारै अक्सिजन क्यापेसिटी अक्सिजन दिएपछि त्यसको स्याचुरेसन बढ्दै गएपछि अनि त्यसले चाहिँ पर्फ्युजन गर्छ के. Okay.
Okay sir.
Any more questions? That was nice. I like that. Anything else? Okay, thank you all. Have a nice day.